the suction may dislodge the blood clots, and ask the patient to not rinse the mouth vigorously, and then ask the patient to avoid smoking because it can disturb the blood clotting and healing. And then give the appointment for checkup after 2 days to see whether the blood is stopped. And then the last one, make an appointment for suture removal after 7 days. That's all from me. Thank you.
Okay, she has covered the wisdom teeth surgery and pre and post-op. Let me see your question again. Okay, explain the procedure and why this is needs to be done. Okay, fine. Just that if we are explaining to Siti, again, the words lah must be more suitable for Siti to understand. Huh? Okay, if you're explaining to surgeons, you must know your audience lah, who you're talking to. Huh? Okay, so everybody, wisdom teeth removal, please learn up. If you have to write, this is it. Then can do, right? So this is revision already for your wisdom teeth removal. Next one.
Good morning to Dr. Sari and my fellow classmates. My name is Ang, and I'll be doing question number 6, which is take informed consent for the removal of 2 molar infected teeth under general anesthesia. So first, what is informed consent? Informed consent is a medical legal requirement or procedure to ensure that a patient knows all the risks and causes involved in a treatment. The elements of informed consent should include informing the patient of the nature of the proposed procedure or surgery, treatment or examination, possible alternative treatments, and the potential risks and benefits of the treatment. So, when we inform the patient, we have to inform the patient that she deserves the right to be informed and decide whether to undergo the procedure after knowing the risk or the unwanted complications. In this case, Siti is told about the examinations done and the risk of the 3rd molar removal under general anesthesia and the complications that may occur during the procedure. Because this removal is under general anesthesia, Siti is also told to fast for at least 8 hours before the appointment, and it may be life-threatening if she does not follow this instruction. So these are the pre-examinations that to be done before the procedures, such as taking history. Examples will be past medical history, previous anesthetic with history, drugs and allergies, social and family history, and past dental history. And then general examinations that to be done, physical examinations, and OPG because Siti is doing 3rd molar removals, vital signs, and airway. So these are the few potential risks and complications that may occur during the procedure. So for 3rd molar removals, we have inferior alveolar nerve damage. If the inferior alveolar nerve is damaged during the removal, there may be dry socket formation, temporomandibular disorders, surgical site infections, damage to adjacent restorations, and fracture of mandible. As for the general anesthesia, there may be complications such as hypoxia, laryngospasm, hypotension, allergies, anaphylaxis, nausea and vomiting, and apnea. So these are the expected post-operative problems, such as difficulty eating, because Siti will have bilateral 3rd molar removal, lower 3rd molar removal, so she will have difficulty eating using the mouth. So you can ask the patient to have a soft diet for a few days, and there may be post-operative pain, which can be prescribed painkillers to ease the pain. So this is the example of the informed consent form for the procedure. That's all from me.
Yo, at least modify it to suit the case lah. The informed consent form ni, upper teeth pun, if you're taking out the upper teeth, fine lah. If not, yeah.
This is
Okay.
an example that we got from Google.
Okay, so anyway, it's well laid out. Hmm. Okay, anybody got any questions on that or not? So if you know, you need to take, if you get a question to take informed consent, you know how to do. Or if you have a patient where you have to take informed consent, this is what you have to say, do, and write. That is your proof that you have told the patient all the risks. They cannot come back and say, hey, you didn't tell me. Then you take out this form and you show them, hey, I told you, see, you sign here. Okay, we got that. This one is important. The wisdom teeth, how you take your consent. Any surgery lah, for us, if surgery, the consent is the most important thing. And the consent must not be taken by the nurse or the assistant or whoever. The surgeon must take the consent usually. Or at least go through the consent with the patient. Okay, just give me 2 minutes, I'll be back. Okay, Arvinda can start.
Very good afternoon to Dr. Sundari and my friends. So my question is, other than the straightforward surgery that my friend mentioned, what is the new procedure we can use for CT? Next slide, please. So my slides is a bit long, but I hope you can bear with me. So we can do these two techniques, which is endoscopic exposure and distraction osteogenesis. Next slide, please. So now dentistry, we are moving into MID, minimal invasive techniques. So the same thing applies to surgery. That's why we have these 3D scans, and basically by using these 3D scans, it helps surgeons to precisely know where we want to do the incision. And second thing is also I read an article saying that by using this minimal invasion surgery, we can actually lower the blood pressure. This is actually a good thing because when we reduce the blood pressure, the overall blood is actually reduced. So that's where bleeding reduced. So when bleeding is reduced, so we can actually focus in that area without keep suctioning. So it creates a better space for dentists to visualize. And second, thirdly is it's
shorten the time because we cut lesser surface area because we do minimal insertion. And lastly, the most important thing, especially for CT, since she's a student, so I don't think she wants a very long procedure. She wants something which is fast, something which is less, something that doesn't cause her infection and cause her more, like she's more comfortable. So this other explanation, I think you can read later. Next slide, please. So this is an example of a scan we can do. Next slide, please. So with advantages, there are obviously disadvantages. So in Malaysia, we don't use it too much because first thing is because of the cost and also because of the specialty, because not everyone is trained to use it. And so one of the drawback is if you're not competent enough and you make a small incision at a site which is not supposed to be, and so basically we do a small incision, right? So if you do the incision at the wrong place and you need a repeated procedure, so in some ways this can be a problem if you're not competent enough, because instead of having one surgery you need two surgery. Next slide, please. So this is the main thing that I'm going to talk today, which is the distraction osteogenesis. Next slide, please. So let's break this fancy word. So distraction is the application of strength. It's basically stretching of the bone. And osteogenesis is basically the bone formation. So when you put them together, it's basically a new bone forming with the help of the tensile forces. Next slide, please. So in CT's case, so in this procedure, I put a short form DO, which is distraction osteogenesis. There's 4 type of device we can use. One is external, one is internal, or another is on the tooth, and another is on the bone. So if you look at the picture, it explains very well. So in CT's case, since she's a 21 years old girl, and she wants to look pretty like a friend, and the most recommended device will be internal. Next slide, please. So how it works, okay, I'm gonna explain with you with my pens so it's better understand. Okay, so just imagine this is a bone, right? This is a bone. Okay, so this bone, just imagine this bone are fused together. So what a dentist does is, a dentist simply makes a cut. So there's a cut here. So there's a gap here, okay? So this gap will fill with new bones. So this is called a unifocal technique. It's when we make one cut. If you look at the picture on top, there's a blue bone and a red bone and a blue bone. So we basically make a cut in between of the two bones so that new bones are formed. So this case is used in CT. There's also 2 other techniques, but I'm not going to mention in depth because it's not for CT, because it's mainly for tumor resection. Because in case of a patient has tumor, so we will actually remove a part of the bone in the procedure. So I can explain, but So just try to look at me and look at my pens, okay? So in tumor, so when you remove the tumor here, so there's a space here, right? Okay. So what we do is we cut another bone, so it becomes like 1 and 2, right? So when we cut the bone intentionally for the process of our distraction osteogenesis, so a new bone is being formed here. So this new bone will help to fuse with the other bone, which is called the transport segment process. If you don't understand, you can text me later and I can explain to you. Next slide, please. All right. So how is new bone formed? New bone form is when your body triggers a new cells to form. So when we cut the bone, automatically there's blood. So when blood is formed, that's where a clot is formed. And this clot will help to bring red blood cells, inflammatory cells, and healing happens. So when healing happens, this is where we bring up the growth factor, and you can read on the slides. It's basically a process where blood helps to form new cells, and it will actually form a new bone. So it says that blood flow during distraction is our process today. It has 8 to 10 times more blood flow at the initial state, because first we want healing what? So once healing is occurred, once the clot is achieved, and then only the blood flow will reduce. And then there's some fancy word, I will explain to you that. Okay, can you go to the next slide? So this is a very important. I did a mnemonic for you guys, so it's easy to understand. So this is the process. What is happening? Okay. First we do osteotomy. Osteotomy is basically cutting the bone. So to cut the bone, we have three techniques. Not technique lah, 3 ways, which is vertical, horizontal, or oblique. So we can cut the bone either in horizontal manner, vertical, or in oblique. And so once we cut the bone already, the next stage happens, which is the latency period. Latency period basically form callus. So what is callus? Callus is a hardened soft tissue. So since Siti is 21 years old, I think her rate of callus is high compared to an osteoporosis woman. It's because she's young, so her ability to form new cells is faster. So after latency period, there's a distraction period. So this is where we form new bone. So after you cut the bone, then there's a gap, remember? That's where our clot form, and that's where the new bone form. So once the new bone is formed, then a process of consolidation happens. This is where the bone matures. So this depends on your body ability. So since Siti is young, she can actually complete this whole process in 4 weeks. But that depends on individual. That's why I made a range 4 to 8 weeks. And lastly is the remodeling. So in remodeling process is when we remove the device. That means if you feel like, okay, if Siti feels like her jaw is sufficient enough, this is where we can remove the device, and the jaw can become to normal. Normal as in normal class 1, not her normal class 2. So next slide, please. So this is a print screen, but I think it's well explained. So you see the first step is when you cut the bone, right? So you cut the bone, and that's where you put the device. You put the device inside, and you can actually loosen the screw over time. So it depends how much, how forward you want the jaw to become. So, and it says that in younger adult, the rate of bone formation is up to 1.5 to 2 millimeter a day. So that depends also on Siti's capability, body capability. So over time, our dentist can actually loosen the screw to we can bring back the jaw to the class 1 position, and up to a level where Siti feels she's beautiful. So next slide, please. All right. So this is step by step what are we going to do in the phase step. So I basically explained, and maybe you can read this later. Next slide, please. Okay, so this is I'm going to explain mostly on pictures because I feel words is something you can read. So remember, first we cut the bone. Once we cut the bone, then there's hematoma. Hematoma is a blood formation. Once there's blood formation, and then there's callus. Callus depends on your body, how fast your body can produce the new cells. So that's when the bone hardens, and lastly, the bone remodeling happens. Next slide, please. So my question was, how is the procedure done? Firstly, we have to put Siti under GA. And then we do a soft tissue insertion. So we can do it in a cervicular insertion. And then next thing we do osteotome. As I said, there's 3 types of osteotome, remember? Horizontal, vertical, and oblique. But an article I read, it says that the vertical and oblique is the best, it has the best prognosis. And then we do the fixation of the device, and then there's a latency period, distraction period, and consolidation period. So this can take up to 4 weeks depending on Siti's body. And lastly, I forgot to say, osteotome is we use fissure burr to make the cut. Okay, and then once we remove the device, that's when the jaw is up to the optimum level for the patient. Next slide, please. So now the question of the hour is, my friend, keep talking about bilateral sagittal spleen, BSSO, and I'm talking about DO. So what is the difference? Next slide, please. So the difference with why my way, which is the destruction osteogenesis, is a new procedure, is because bilateral sagittal spleen osteotomy, it makes it makes a longer cut as compared to destruction osteogenesis. So as I mentioned, when the cut is smaller, the healing is faster. So especially for CT, a university student, it makes her feel more comfortable. So in this research, it shows the difference between BSSO and DO. So it says that in BSSO, there is we can actually injure the inferior alveolar nerve, and also in this process we can cut the periosteal stripping because we make a larger cut as compared to in DO. So in my advice, I will say that if CT wants to have a minimum risk to her inferior alveolar nerve, I think DO is a better option. Yes, next slide, please. So the last thing I'm going to mention to you is endoscopic technique. So previous. Okay, actually there is two technique in dentistry we are using right now, but it's not really mentioned in the book. It's mostly in articles. So there's two technique actually. One is laparoscopic, one is endoscopic. Actually, laparoscopic is a better way, but the article that I want to read, I got to pay. So I'm gonna talk about endoscopic. So next slide, please. Okay, what is endoscopic? Endoscopic is basically an extra eyes for a dentist. So we use a device let's say we're gonna do for CT. So we put the device into CT's ramus, and then in this way, and when we insert the endoscopic, there is like a camera projecting to a monitor. So especially in dental learning school, it's very good for us to learn. Like we can get our hands on from seeing the monitor and also seeing what's exactly happening at that time. And that's about it. So the laparoscopic device is like an indirect observation for us, so we can make less errors. Example in like we can avoid damage to your inferior alveolar nerve block. Inferior alveolar nerve. Next slide, please. This is not only used in orthodontic surgery, it's also used in other surgeries, which is the TMJ and other fields in surgery. Okay, so what is the difference is in normal surgery, the surgeons cut 3/4 of the full length of the mask of the length. Sorry, it cuts 3/4 of the full length of the area. But by using this minimal invasion technique, we can reduce up to 1/4 of the size. So it creates a very, very small insertion. And with that said, smaller insertion can lead to better healing for the patient. Next slide, please. So this is my last slide. So this is basically what is happening. Endoscopic, if you look at the picture down there on the right, this is how it's actually done. But I don't really have a lot of pictures because there's not much evidence, as it's still a growing field in dentistry. So it allows better ability for dentists to see, and I think you can read this. It's what I've explained by more words. So thank you very much.
Okay, Arvinda, well done. Actually, I just expected you to go into the distraction osteogenesis, but it's good that you've taught us about the minimally invasive surgery as well. Distraction osteogenesis we use when there's large movement, because if you just do orthodontic, the result may not be stable. And then in retrognatic mandible, you're going to be stretching the soft tissue. Like Siti's friend, where she had prognathic mandible, you're moving back. So that means the soft tissue already stretched. It will be more stable. Whereas in Siti's case, you're going to move the mandible forward. So the soft tissue envelope, the face and the the facial, the cheek mucosa and all that is going to be stretched. So if we have to move it a lot, it will relapse. After some time, it will go back to its old position because the soft tissue, the muscles and all are going to pull it back. So it may be a good idea to do distraction in such cases where you have to move a lot because the soft tissue also slowly enlarges. Like the pregnant lady, as the baby grows, the abdominal soft tissue grows as well, right? Same like that, this also the soft tissue will expand to accommodate. Okay, and in distraction, the disadvantage of alveolar nerve damage is both also can get lah, because this also you have to cut the bone, you see, so you can damage the inferior alveolar nerve as well. And in distraction osteogenesis, basically, show me the slide where you had the bone healing with the callus and all that. Okay, this one. So the first one, as soon as we cut, there will be this hematoma formation. Then they have this fibrocartilaginous callus formation. That's why during the latency period, this happens. Then after that, they start moving the parts of the distractor apart. First, they are both together. Then that means you are stretching this fibrocartilaginous callus. Research has found that you can stretch this and it won't pecah, So you have stretched it. So now the bone callus number 3 will form in this stretched fibrocartilaginous callus. So maybe you have calculated that maybe you have to move it. You can expand it 1 centimeter. They come in different. The distractor itself comes in different amount of movement. Can make different vector. That means different direction, anterior, posterior, or laterally, or 30 degrees curve, whatever. Depending on what the case is, we have to decide lah. We have to calculate and say which is the best distractor. Then we stretch the fibrocartilaginous tissue over that 1 week, every day 1 millimeter, or half 0.5 morning, 0.5 night. And then at the end of it, when we are finished stretching this callus, we hold it in that position and let number 3, the bone callus, to form. Inside now our stretched fibrocartilaginous callus. So you understand the procedure for distraction osteogenesis? And then the bone will remodel finally. So here we have made new bone. So in that space there, we have grown new bone. That's how the mandible has elongated anterior posteriorly. So this is more stable result. And while we are stretching the fibrocartilaginous callus, the soft tissue also stretches with it. And bone, there's something holding it there. So it won't go back, or lesser chance of it going back. And Siti doesn't decide whether she looks pretty and whether it is okay or not. It's all been decided earlier what is best based on the calculations and the tracings that we have done. Okay? This one you need to know lah. You need to know. You're not going to do it, but at least you need to know when people say distraction osteogenesis. And when you talk about distraction osteogenesis, you must talk about this guy known as Ilizarov. Ilizarov was a Russian orthopedic surgeon. He discovered during World War II, when he was treating the soldiers, that if he used this device and he could stretch the callus, those people with their fractured bone, they won't have shortened leg. He can, give them longer leg. So that has been extrapolated to be used in other bone, mandible, maxilla. Okay, anybody got any question here? This one you must know lah. You cannot be, you must know, because you are in the field. You cannot be somebody who doesn't know this at all. Okay, Arvinda has done quite a lot of research on it and showed us this. Okay, who's next?
It's me. Okay.
The last person first, is it? Okay.
Yes.
Okay, Athena.
So good afternoon to Dr. Sundari and my friends. So I'm gonna do the last question, which is Siti has decided to proceed with the orthodontic surgery option. And after all the needed treatment, she is ready for surgery and has come for admission today. Take informed consent for the surgery to be carried out tomorrow. Next slide. So what is informed consent? It is the process of providing patients with the realistic and necessary information in a manner that the patients can understand and recall. And so with this information, it will help them to make an informed choice on the treatment. And this informed consent is also a medical legal requirement or procedure. It is so that the patient will know of the risks and the costs involved in the treatment. So what do we usually include in an informed consent? It is the nature of the surgery or the procedure, and also the treatment. And if there is any alternative treatments, it must be included in the informed consent. And we should inform the patient of the potential risk and benefit, and also the cost of the treatment. And for the patient to sign the informed consent, the individual must have an adequate reasoning capacity, meaning that the patient must be able to have a cognitive capacity where they can decide whether they want to do the procedure or not. And so before the informed consent is signed, the information can be shared by the doctor either verbally or in writing, and it is usually repeated during treatment planning. And so the written informed consent will be taken before the operation. Next slide, please. So the first, what will be included in the informed consent is the nature of the procedure and surgery. So the doctor would have explained about the nature of the procedure or surgery to CT, and it is included in the written informed consent, meaning that in the informed written consent, it will say the procedure, I agree to the procedure, which is either it is BSSO or maybe distraction osteogenesis, and CT must agree to that. And also CT is aware of the involvement of teeth wiring and the possible complications. So maybe after the surgery, there is a need for teeth wiring, and it should be included in the informed consent. And the complications must be written down as well, meaning CT knows that the teeth wiring will result in reduced oral hygiene, resulting gum disease and compromised nutrition. And CT must be aware as well that there is a need to carry wire cutters at all time when the jaws are wired in case of any emergency. And for this kind of surgery, it is usually a major surgery, so it will be performed under general anesthesia. And so the potential risks associated must be informed as well, which include bronchitis, pneumonia, hoarseness of voice changes, any cardiac irregularities, and it should be informed that there is a potential risk of death as well, and allergic or adverse reactions to the medications or the material used. And there is usually a lack of coordination even after the surgical procedure is over. So the patient should be informed, and the patient should be aware that even after 24 hours, there will be a lack of coordination. So maybe the patient cannot be released immediately, and patient should have someone to bring them back home. And CT must agree to not have anything, which include clear liquids, for 8 hours prior to the surgery, because it may lead to life-threatening condition. Next slide. And CT should also be aware that she has discussed of her medical and health history, which include the dental history, whether CT has any medication or any recreational drug use. This should have been given to the doctor by CT before the operation. Next slide. And CT should be informed of the course of treatment as well. So it is not just during the surgery, but CT must be informed in the informed consent that even after the surgery, she may need a minimum of 4 months of regular visits, and there is a need for elastic treatment, jaw exercises, and CT should take the medication as prescribed. And also in the informed consent, CT must be aware that she needs to give compliance and cooperation as well, and that a lack of compliance will result in less than optimal results. So it's not just wholly the surgeon's responsibility, but a responsibility of the patients as well. Next slide. So then the potential risk of the treatment must be included very thoroughly in the informed consent. So it may arise with the surgery, the drugs, And so there might be facial and jaw swelling after the jaw surgery, which will last for about 2 to 4 weeks, depending on the individuals, and bleeding during or maybe after the surgery. And it might be severe enough to require blood transfusion. And also pain, bruising, delayed healing, even there's minor things such as cracking, stretching of the corners of the mouth, and also the damage to the TMJ, difficulty in opening. And the nerve injury must be included as well, and it should be emphasized that this condition may resolve over time, but in some cases may be permanent, and this must be included in the informed consent. Next slide. And so allergic reactions, phlebitis, and also changes in the speech, swallowing, loss of the muscle functions, and they may be a muscle spasm as well. Even the failure of the bones to heal might occur after the surgery, and relapse might also be present, and that should be noted, and patient must know about the possibility of relapse as well. And next slide. And in case if the maxilla is also need to be cut, and not just the mandible, so patient must be aware of the nasal septal deviation, and there might be changes to the appearance of the teeth, and this may be permanent or it may resolve over time. Next slide. And in the informed consent as well, patient must be aware of the course of treatment, and patient must have already discussed this with the surgeon before before undergoing the operation. And so she must be aware of the treatment cost and agrees to pay for the stipulated amount. And also the surgeon must disclose of that there is no guarantee to the result. And if there is a need of additional treatment, then CT must be able to pay for the additional treatment. And the next slide. And possible alternative treatments also must be discussed with CT and the surgeon before the surgery. And CT must be made aware that if she is under general anesthesia and during the surgery there is a need for modification, then consent must be given to the surgeon for the best interest of the patient. So this is a template model that I got from Google. Okay, and that's all from me.
Okay, that's done well as well. Another thing I remembered is this one, orthodontic surgery, the plates and screw maybe cost 1,500 to 2,000. But distraction osteogenesis, one side itself maybe about 15,000, 20,000. So two sides means we're talking about 40,000, 50,000. That's why we don't use so much of that. Yeah, it's cost. It's all coming from overseas, Germany lah, or UK lah, America lah. So that's why the difference in cost as well. Otherwise, distraction would be a better thing to do than just orthodontic surgery, especially when a lot of movement is involved. Okay, so consent form taking is very important for you all. Explaining procedures to patients is very important for you all. Giving patients post-op instructions on what to do also very important for you all. All these things is what you will do because you are a young dentist. Biopsy, maybe you will do, maybe you will explain. Yours is more like telling patients, So for you to be able to tell patients, you must know it yourself. Okay, anybody got any questions? Everybody can take consent? Yeah, consent form must have patient's name, must have doctor's signature, must have patient's signature, must have witness signature, must have all the risks written down, the cost also written down, because nowadays cost will become a dispute, then you have problem lah. Or you have some separate form where the cost is written and patient agrees to it. Even your crown and bridge implant, all that also, sometimes the cost may become a dispute, so you need to tell them ahead everything properly and then agree, then only do. Anybody got no questions? Then we go on to the, who's next?
That's all from us.
Ang and
Ang has presented just now.
Which was Ang's one? Tell me, Ang.
I did number 6.
Show me again. Oh, okay. Okay, remember Ang's presentation and Arvinda. So your group has 8 people. Adila till Atina, correct? Adila, Afika, Ahmad, Aimi, Amnani, Ang, Arvinda, and Atina, correct?
Yes, doctor.
Yes, doctor.
Okay, so this group has done quite well. This is a very good revision for you on consent taking, on informing patients what to do, on distraction osteogenesis, on orthodontic surgery, the different stages in orthodontic surgery, because that's what the patients will want to know. Yeah, how they have to go to the joint clinic, how they have to decide on the treatment needed, the different investigations that has to be done,